I was able to stay at work and get some work.
All right, welcome everyone to the Emerging Specialty series on Cardio-Rheumatology, getting to the heart inflammation. This is a very exciting series you have started in California ACC. I'm Jamal Rana. I'm serving as the president of California ACC, and I'm thrilled to have esteemed faculty here today. I'll just start off by thanking our stellar board member, Dr. Reach Singhani, who's at Stanford, who was able to use her resources and contacts to get our more stellar faculty from Mayo Clinic and UCSF. And I'm really grateful for Dr. Mankad and Dr. Graf to be here, to volunteer their time and use their knowledge and wisdom for all the audience today. And I'll hand over to Dr. Reach Singhani. Thank you all.
Thank you so much for that kind introduction, Dr. Rana. Well, I echo those words. We're very excited about this event, and I'm excited to be your moderator for tonight. Just a little bit of background. This is an emerging subspecialty in cardio-rheumatology, and I, with my colleagues at Stanford, we developed a cardio-rheumatology clinic, and my interest in the field actually began in my ECHO fellowship, where I had the benefit of being mentored by a cardiologist and a rheumatologist. So we're trying to recreate that tonight, so you can see all the perspectives. And as part of that, we're very excited for our panel today. So we have our esteemed speakers, Dr. Rekha Mankad. Dr. Mankad is a cardiologist and echocardiographer at the Mayo Clinic in Minnesota. She also serves as the director of the Women's Heart Clinic, and she has a specialized interest in patients who have autoimmune disease-associated cardiovascular disease, and she runs a cardio-rheumatology clinic there. She's also published extensively on heart disease in women and in the field of cardio-rheumatology, so please join me in welcoming her tonight. And our second speaker is Dr. Jonathan Graf. He is a professor of rheumatology at the Zuckerberg San Francisco General Hospital and UCSF. Dr. Graf is both a master clinician and a translational researcher. He directs the UCSF Rheumatoid Arthritis Observational Cohort, which has enrolled more than 830 patients to actually study the effects of rheumatoid arthritis, and his research focuses on cardiovascular disease in those patients. Dr. Graf is also an outstanding teacher, and he's won numerous teaching awards at UCSF and has been elected a UCSF Department of Medicine Master Clinician. So welcome to both of you, and thank you for being here with us. All right. And I like to do acknowledgements early because we tend to run out of time at the end. So I am going to say that this event and the series of events would not be possible without this group of people. So we have our ACC leadership, Dr. Rana and Dr. Hilliard and Liana, who have been instrumental in making these events possible. And my partner in crime, who is here today, Dr. Connor O'Brien, who actually kicked off this series with an event on critical care cardiology. And that's actually on the California ACC website if you'd like to see that at another time. So quick roadmap for the session today. So we're going to start with our introduction for a few minutes, and then we're going to go on to a moderated discussion with Dr. Mankad and Dr. Graf. And then we'll have a Q&A with the audience. So feel free to type anything into the chat and we'll save that for the end, but we will allot some time to that. All right. So now I'm going to take you all on a little bit of a journey back to the 19th century, where this painting by Jean-Baptiste Camille Corot showed up about a century later in JAMA. And this requires a little bit of artistic license, but they describe boutonniere deformities of the fingers, swelling of the MCP joints, and perhaps some tophi in the wrist. And Camille Corot himself was thought to be suffering from gout. So, this shows us that the prevalence of inflammatory joint disease has been around for a while and has been seen in societies. And the implications of something that has been around for a long time is what we're planning to discuss today. So inflammation-mediated cardiovascular disease has been actually well described by many groups across the world. And the way this affects the heart is it's an interplay of patient-associated risk factors, which you can see on the left of the slide, and the rheumatologic-associated, cytokine upregulation. And it's kind of a bidirectional feedback loop where these risk factors are affected by the cytokine upregulation, and that further leads to accelerated atherosclerosis. So this is well described, but how we can kind of mitigate risk for these patients is something that, a lot of future research is looking into. So just to quickly go over the most described cardiovascular manifestations, again, there's not a whole lot of research in this field, but certainly Dr. Mankad, Dr. Graf, and others are trying to add to this. Rheumatoid arthritis probably has the most research behind it. And in fact, the European League of Rheumatologists, so the European societies, actually have come out with guidelines most recently this year, which really does describe that the risk in rheumatoid arthritis parallels that of diabetes. So, it allows us to actually increase for standard scoring models like the ASCVD risk, it allows us to increase the risk factor by a factor of 1.5. So you can add to that risk, and perhaps these patients with RA, we should be treating them like diabetic patients and being very aggressive with their LDL lowering and prevention. And rheumatoid arthritis can affect many other layers of the heart, and it can cause pulmonary hypertension. But pulmonary hypertension and autoimmune disease has different mechanisms. For rheumatoid arthritis, it tends to be more related to the lung disease. And in this population, we often see things like arrhythmias as well as autonomic dysfunction. This has all been well described. For lupus, again, lupus is also pretty well described, and the cardiac manifestations not very common, but can be quite catastrophic. And sometimes, the patients we've taken care of can actually have cardiac manifestations as their presenting symptom of lupus, and that tends to be quite severe. Pericardial disease is quite common, relatively speaking, and valvular disease, especially something like Liebman-Sachs endocarditis, can be seen in association with antiphospholipid antibody syndrome or with lupus alone. The myocardial disease actually tends to be not that common, but pretty catastrophic when it happens. So lupus-associated myocarditis can make patients very, very sick. And pulmonary hypertension and lupus is actually usually a function of something called thrombotic arteriopathy, where there are tiny, tiny blood clots in all these vessels, and over time that can increase the pulmonary artery pressures. And coming to scleroderma or systemic sclerosis, something we take care of a lot in our clinic, and can be a very difficult disease to manage for rheumatologists and cardiologists. It is one of the few diseases where there are clear guidelines that we should be screening every year with an echo. And if there's any concern for pH, then we should be doing right heart caths, because this is, it can develop insidiously and it can be pretty catastrophic. But the other thing about scleroderma, which is not as much spoken about as much, is, over a long period of having hypertension, renal crises, there can be systolic and diastolic dysfunction. And myocardial fibrosis, so a similar scarring pattern that you see in other areas of the body, can occur in the heart. And we actually do have a patient with this where we've demonstrated mesocardial scar through an MRI, and that can lead to a cardiomyopathy. So these are the rarer findings, but can have significant implications. And this is the area where I did my research. So fairly well described in the spondyloarthropathies, particularly ankylosing spondylitis, is the aortopathy, diastolic dysfunction. But a lot of these studies are from the 1950s to 1980s, so they're very old data. And so what our question was, we're not seeing this as much as it's been described in textbooks and other papers. So is there a reason are patients getting diagnosed earlier? Is inflammation being treated earlier, and are we seeing less of this? But what has been described is the aortic disease, as well as LV dysfunction and arrhythmias. And then lastly, Takayasu's. Not lastly, but one of the ones we take care of a lot is, a panarteritis, which through different mechanisms, including scarring of the aorta and other blood vessels, can lead to myocardial disease and pulmonary hypertension, and tends to affect younger women. Now, while we say that, I described a few conditions, these are the kind of patients we see the big spectrum of autoimmune disease. And even this is not complete, because many patients have undifferentiated autoimmune disease. Many patients have components of these different syndromes. And a lot of these patients will have cardiovascular manifestations, and some will just have cardiovascular symptoms and no, demonstrable cardiac disease. And I think, part of the field that's evolving is how do we take those patients who don't have cardiac disease but have autoimmune disease and be very focused on prevention and make sure that they don't develop things. And I think that's really where the field is going in the future. So that brings me to future directions for research. And, these are questions that are actually being answered, in fact, by two of our panelists, amongst other people. Is this disease, is the prevalence truly lower now when patients are being treated early and aggressively for their autoimmune disease? The feeling is yes, there's some early data that suggests that's probably true, that if you can modify the disease, then perhaps you can modify the cardiac manifestations. But I don't think we have enough data to say this with, to apply it to screening and guidelines. And then how do we find those patients who are most vulnerable? Traditional screening scores and traditional risk factor scores work pretty well for cardiac disease in the general population. But we do know that the lipid guidelines and the prevention guidelines have evolved now to include autoimmune disease as a risk enhancing factor. But are there other biomarkers or markers of autoimmune disease that can actually tell us which patients are at highest risk so we can be more aggressive, the way we kind of are thinking about rheumatoid arthritis and lupus now? And then, having a standardized diagnostic and treatment protocol for symptomatic patients, and seeing how we can incorporate rheumatologic risk factors, disease factors into prevention tools. I think these are some of the future directions, but we'll hear more from our panelists. And then that brings me to how we may structure a cardio-rheumatology program. As you can imagine, this is not a field that is, very prevalent across the country or across the world. There are very few centers that do this, but a lot of people take care of these patients, and a lot of cardiologists have experience with this. It's just not kind of corralled together. So when we're designing a program like this, needs assessment in parallel with kind of what population you're taking care of, I think is really the foundation. And then having standardized protocols, not just for treatment, but also for imaging. And that's where, someone like Dr. Mankad, who's an echocardiographer, that really, is important, because how do we design these protocols? And actually the European Society for Imaging for MRI actually came out with a recent set of guidelines. So it's helpful. So that these things are actually happening in practice now. And then the next step, of course, is building the expertise. And this is not a single person field. This is definitely cardiology and rheumatology. So that collaboration is critical. And that's what we're going to hear about tonight. And then working more on research, scholarly activity, and then training people so that, there are more people who are involved in the field. And I think our ultimate goal is, because there are such few centers, how do we have a national collaboration and build up a registry of our patients so that we can all learn from them? So that is how we will move the field forward in the future. And then I think we do have a few minutes to go over this case that I wanted to share with you before we move on to our questions. So this is a patient we took care of in clinic. Literally, I think it was my first month as an attending. So this is how life unfolds. But this is a 32-year-old female who was diagnosed with lupus about 10 years before I saw her. She was well controlled on hydroxychloroquine, didn't really need steroids. And then 1 year prior to this presentation, she started to have renal involvement. So she had proteinuria, they did a biopsy, and she was started on Sept. And then she had a very astute rheumatologist who she started to have this, it was very subtle in retrospect, but she did have some inspiratory chest pain. Later on, she told us perhaps she had exertional dyspnea. And he did an EKG, it looked fine, but he also did an echo. And she had an echo about 3 years prior, which was absolutely normal. And so she came to me after she actually had the echo, and I'll show you some images from there. Hopefully they'll play. So this is the RV outflow view. So you can see this is the pulmonic valve. And I think this might be playing a little bit slowly, but you can appreciate how thick that valve is. And this is a TEE where you see the pulmonic valve really nicely. And it was actually 8 millimeters. We did an MRI later, so very, very thickened. And then these were the gradients. So really very clearly moderate pulmonic stenosis. And the pulmonic regurg at that point was probably about moderate as well. And again, this is someone who was absolutely fine 2 to 3 years ago, and this is pretty quick. And her lupus, for all other counts, seemed fairly stable, but her complements were low, which can be kind of a marker of worsening disease. And so we did do an MRI just to see, because we couldn't see on the TE, we couldn't really see vegetations clearly. But the MRI also reported thickening without any clear vegetations. And right at this point where we're starting to worry about her, she tells us she has blurry vision. So then, that hit the panic button. We did a brain MRI, and that looked fine. But I think for lack of a better diagnosis, we call this Libman-Sachs endocarditis, because everything was pointing to that. And it's a manifestation of her lupus. She doesn't have antiphospholipid antibody syndrome, just lupus. So we started her on the rheumatologist started her on a high-dose prednisone taper. And eventually they added more to her immunomodulation, and I put her on warfarin because, anticoagulation is the treatment that's described. And 2 months later, we got a repeat echo, and again, I hope it plays. Well, I hope you can see that it's a little bit thinner, but the most important thing is the gradients went down. So they went into the mild range. She felt better, so her dyspnea improved, her orthopnea improved. And for about 4 years or so, we've managed to maintain this now. We have 4 years of data. So she really has mild PS and her valve hasn't gotten worse, her RV hasn't gotten worse. So that seems hopefully, to be at least managed for now. And then so I take you back to 1924, where this paper came out by Emanuel Libman and Benjamin Sachs, where they actually described the first few cases of Libman-Sachs endocarditis, which really has these kind of wart-like or verrucous vegetations. You see fibrin, you see thrombus, and they tend to be on these valvular surfaces, and they can embolize, and that's the big risk that you can have strokes and other catastrophic findings. And now, before we move on to our moderated questions, I will leave you with one more piece of art. This is a painting by George Seurat, and it is made with a technique called pointillism. So I thought that was a nice thing to share in the world we live in today, where things are sometimes not so great. But in medicine and in cardio-rheumatology, I think if we all, these little points, they make something beautiful. So I think if we all collectively work together, we can create masterpieces. And with that, I will end and we will move on to our questions. Okay, so I'm going to stop sharing so we have our panelists. All right, so I'm going to go straight into questions. What I'm going to do is I'm going to read out the question and put it into the chat so everybody can see it. This first question is for Dr. Mankad. Describe your career pathway, highlighting your clinical and research things that you've done in that arena would have helped you build a career in cardio-rheumatology.
Well, first, let me thank you very much for the invitation. It's a pleasure to be here. It's somewhat surreal to be considered an expert in something given my career trajectory. So this is kind of cool, I would say. So as far as how I got here, I started actually as a clinical cardiologist in private practice before I came to Mayo. And when I came to Mayo, I was in the women's heart clinic. That was sort of my niche, dealing with women and heart disease. And I can remember very clearly being referred a patient sent by rheumatologist for cardiovascular risk assessment. I believe the patient had lupus. And my first thought was, what? Why are they sending this patient? This was now over a decade ago, maybe almost 15 years ago. And I didn't understand why. And I actually started looking at the literature and I went, wait a minute, why don't I know about this? And the rheumatology literature had tons of information about patients with RA and lupus having increased risk of cardiovascular disease. And I was perplexed why that never sort of got translated into the cardiology realm. So I actually went to our rheumatologist who had done a lot of the work. And I said, wait a minute, how come this is all out there, but nobody's doing anything about this clinically? So they were very excited for me to start an actual clinic where all this literature that was out there could be hopefully sort of translated into the care of the patient. So I started I started a cardio-rheumatology clinic now probably a decade ago almost. And it really started as a preventative clinic, really to talk about risk factor assessment in the high-risk patient. And it started mostly with RA patients and lupus patients, and then it's sort of has filtered to all autoimmune diseases. Most of my referrals come directly from rheumatology and sometimes internal medicine, and some patients sort of have searched and found me as well. So that's how it started, and that has sort of gotten me excited about all aspects of the sort of the connection between autoimmune diseases and the heart. I have an interest in valve disease. I work in the valve clinic. So the non-bacterial thrombotic endocarditis is very fascinating, and we've seen some very interesting cases there. So I work mostly with sort of prevention, coronary disease, valve disease primarily. I don't do as much in the myocardial disease or PH or the arrhythmia world in these patients. But I sometimes start the process and then refer on to colleagues for more of those subspecialty care.
Wonderful. Well, thank you so much. And exactly, it's more than just cardiology and rheumatology. There's so many other kind of, especially we have a PH clinic, so they handle some of our scleroderma. So that's wonderful. All right, well, moving to our next question. This is for both of you, but I'm going to start with Dr. Graf first. So as this is a multidisciplinary field, describe your collaborations with cardiology, highlighting how you manage complex patients together.
Well, it's a great question. I think one of the beauties why I got into rheumatology in general is I felt it was sort of a consummate specialty which interacts with every other medical specialty out there, because almost every organ can have an immune system component to it. And so why not the heart? Right? It's sort of, I felt that was kind of a fertile area to sort of get involved in and build collaborations. And so, although you asked the question specifically about clinical stuff, I'll start with a little bit of research because my initial collaborations began here at the General, where we are very, very fortunate, as some of the people on this very call can attest to personally, have a fantastic cardiology division here. Several previous presidents of the National American College of Cardiology have come from here, and have always been very, very approachable, both to colleagues like myself and to house staff and students the like. And so I developed a collaboration out of a research interest with Peter Gans, who was the previous chief of cardiology here, and Priscilla Shu, who's the current chief of cardiology here, both of whom have an interest in the relationship between inflammation and cardiovascular disease, and have developed various models to look at preclinical cardiovascular disease in HIV and other factors. And so it was a natural ask for me to get involved with them to say, hey, are you guys interested in looking at not micro-inflammation, such as you see in HIV, but how about macro-inflammatory diseases like rheumatoid arthritis and lupus, where the inflammation isn't subtle and beneath the surface. And so that has begun a long-standing collaboration that we've had both research-wise and eventually clinically wise as well. So that's how I got my interest involved in and a lot of my connections into the sort of cardiology world over here. Clinically, like I said, we one of the frustrating things being a rheumatologist is that we don't own an organ. We own a system. We own the immune system, but in some ways, so we fight with allergies sometimes over it. Often when systemic immune diseases present in an organ-limited way, which they do sometimes, they'll present in the lung, for example, in somebody with isolated interstitial lung disease, or they'll present in the kidneys with isolated glomerulonephritis. It can be a little bit frustrating sometimes because we really need to rely on our colleagues in the other subspecialties to collaborate with. We don't do kidney biopsies in rheumatology. Our nephrology colleagues or interventional radiologists do. We don't do lung biopsies or bronchoscopies as such. And in the cardiology world, we don't do echoes. We don't do endomyocardial biopsies. We don't do a lot of things that I think are sometimes very, very necessary to interrogate this specific organ. But in our rheumatic diseases, the heart is much, much more often involved than I think anybody would imagine. Whether you're talking about garden variety cardiovascular, atherosclerotic cardiovascular disease, and risk assessment and referring those patients like the lupus patients for which I would characterize, by the way, as having much, much more increased cardiovascular risk than even RA or the other diseases. That's a very important collaboration there. But it also includes other diseases, like you mentioned. I don't know how many people have read the New England Journal this week, for example, but there's an excellent case in the New England Journal. I'm not going to spill the beans right now, but it's a rheumatoid patient who presents with a whopping pericardial effusion. And the etiology of that effusion turns out to be quite a surprise. So, I think, it's very, very important for we in rheumatology to build collaborations with our colleagues in the cardiovascular fields as well, not just because we have someone presenting with a specific need that we have. We need a biopsy, we need a cath, we need this, or we need that. But a lot of times we need cognitive input as well. And I think as the cardio-rheumatology field develops and more of these diseases and their disease manifestations within the cardiovascular system are recognized, I think that cerebral acumen will continue to evolve as well, and our collaborations will become richer. So I can tell you, I mean, I'm on the consult service here right now. We've had 3 patients already this month. We had a mixed connective tissue disease patient who presented with complete heart block here to the hospital. Okay, now she had lots of reasons. She's in her advanced age, this particular patient, to develop heart block organically. But we know that mixed connective tissue disease, if it has a scleroderma type component to it, can infiltrate the heart. That's one thing. This is a woman who's been on Plaquenil for a long time. We know that Plaquenil can have both effects on the conduction system as well as an infiltrative vacuolar myopathy that can occur, cardiomyopathy as well. So there are medication effects that we have to consider. And there are other things. So, you know, I think that's a typical case where getting our cardiology colleagues involved, getting the necessary studies that we need and the cognitive input we need and the clinical expertise is very, very beneficial. So I applaud you guys in starting. We don't have a cardio-rheumatology clinic here yet, but I think that's the way of the future.
Well, thank you so much, Dr. Graff. And, you know, there are 2 things. One is the systemic part of it. I completely agree with you. I think part of the reason I went into the field is because it's systemic cardiology in a way. So we get to learn about other things as well. But then, you know, moving on to Dr. Mankad, I think one thing I feel, you know, in practicing in cardio-rheumatology is if there's something really bad going on, we still need to talk to the rheumatologist to fix the underlying problem. So take some of the heat off. I mean, we still have to do things for the heart, but you know, what is your kind of experience with collaboration with rheumatology?
So, I've become sort of the point person for rheumatology. I mean, I think since I started this, I'm kind of their go-to. So that's the first thing. And in some ways that makes it easier and harder depending on who you are, but it certainly streamlines things as far as for them who to contact if there's something they want to get addressed, looked at, questions about. So I get a lot of inbox messaging from the PAs in rheumatology. And so that's kind of nice. And so, I mean, again, there's a lot of direct communication just through the electronic medical record. Then when it becomes, you know, that patient with a systemic, you know, so it has cardiac manifestations, has their rheumatologic condition, then it really comes to, do we think their disease is adequately controlled? And I think just like the cardiologists and the pulmonologists sometimes, you know, beat head, it's the heart, it's the lungs. I think, I don't say we bump heads, but I have this sense occasionally that I think, you know, again, and I'm not the rheumatologist, where I feel like, okay, I think we need to get more aggressive with the treatment for the rheumatologic condition because there's something happening here. The cardiac stuff is progressing. It's more aggressive than it should be. So that's when, again, I'll talk to my rheumatologist and say, I'm worried. I think we need to do more because I can only throw so many meds if the inflammation and the underlying disease is running a little bit rampant. My meds aren't going to take care of that. So I think that's where it's a lot of communication. So again, we kind of, in some ways, it'd be nice to be able to sit in the same clinic and talk about patients together. That's probably a utopia. I don't know if that'll ever happen, but that's how we function in some ways, where we're sort of directly connected, and I can call somebody, they can call me, and it works out pretty well. And then because of my interest, obviously I've had colleagues that have sort of taken it on as well. So if I'm not available, they are. So it's not as collaborative in some ways. And so, you know, it is one of the challenges as well, is how do you truly come at the patient with like both providers being able to see them almost like one after the other to really discuss and mesh. I think that's very hard in this day and age, but you know, something that acts like that would benefit the patient long term versus, you know, the rheumatologist saw the patient 2 months ago, referred to cardiology. By the time I see them, disease activity is different than what it was 2 months ago. And so there's that disconnect. And then it starts getting difficult for the patient to know how best to approach their various conditions because there's this time lag and changes over that period of time.
Yeah, absolutely. And I do agree. I think when the patient's heart is getting worse in a cardio-rheumatology patient, my first call is to the rheumatologist. What are we missing?
Mm.
And that you can't do that with other patients for the most part. So this is kind of nice. And sometimes, sometimes it's subtle. Sometimes the rheumatologist will say, well, nothing looks off. The inflammatory markers are under control. But sometimes then we dig a little deeper and see if we can adjust medication. So it's a beautiful field for collaboration in that sense. And so then going on to my next question, which is for
It is.
Dr.
Let me just add one quick
Yes,
thing there. I mean,
please.
I'll double what was just said. I think it's really important sometimes. I mean, we take great pride as rheumatologists in trying to do a little bit of everything, but when you do a little bit of everything, you're an expert in nothing, right? So I always have to continue to remind myself that. So yeah, I can read CT scan, chest CTs, right? But truly, if there's a subtle gestalt that somebody is getting better or worsening in terms of their ILD, I need to hear that from the pulmonologist. When I get referred, patients with eye disease from the ophthalmologist and they want me to help them manage the immunosuppression that they're not comfortable with, I am absolutely, totally reliant on what the ophthalmologist can see inside the eye to tell me are things responding or not. And I think that's very important in cardiology as well. I mean, I can read an echo report, but I can't read an echo, and I think it's sometimes really important, nor do I have the facility or the tactile touch, to be able to understand, is somebody generally improving, not improving, is something working, not working? Are the wave flows you see through the pulmonic valve indicative of improving, pulmonic stenosis or not, really? And because there are raw numbers that you look at, but it's your impression and your expertise that matters the most. So communicating that back to the rheumatologist is really important. So the rheumatologist knows, hey, if you're really worried about something more than I'm getting from the raw data that as best I can interpret, I need to know that so that I can adjust the therapy appropriately.
Right. No, and that's so true. And I think, like the case I presented, that was the primary manifestation at that time. And, so the patient was flaring through their cardiac disease, which is not the most obvious thing sometimes. So I think it is all about that discussion. So my next question for Dr. Graf is, as a rheumatologist, and you've touched on this a little bit, but maybe a little bit more in depth, is, what aspects of cardiovascular care do you think in developing a cardio-rheumatology program, what aspects of cardiovascular care do you think we should focus on the most?
So a couple of things. I think, before I even get into the specifics, the general things that improve. So we've learned over the last decade or a little bit more that combination clinics of combination specialties improve patient outcomes and patient care. So we have, for example, many examples around the country of myositis clinics that are a combination of neurology, rheumatology, and probably pulmonary medicine as well. We have pulmonary rheumatology clinics. We have renal rheumatology conferences, co-management conferences here at UCSF. And I think, so the thing that really benefits there more than anything else is the timely communication that I think, Dr. Manka just referred to a few minutes ago, that sometimes there's a disconnect between when something is appreciated and when the communication gets to somebody else to act on it. I think when people are sort of together within the same common space, even if they're not seeing the same patient at the same time, just to be able to go across and knock on a door and say, hey, I want to just talk to you about someone, makes a big difference and can overall improve patient outcomes. Specifically, the low-hanging fruit is cardiovascular risk stratification. I think a lot of our patients, as the European guidelines you pointed out have emphasized now for 5 years, their cardiovascular risk is underappreciated. This was rammed home to me when I was a resident 20 something years ago, and came downstairs to admit a 27-year-old Pakistani male who presented with chest pain and had a history of lupus. And he was billed as having pericarditis, but no one ever checked the troponin on him. And sure enough, the guy had a massive MI. And I think just recognizing that the cardiovascular risk that these patients have, lupus patients, probably 50-fold increased risk over the general population. RA patients, as you said, more along the lines of actually a poorly controlled diabetic. I think getting appropriate cardiovascular risk stratification screening and prevention, I think, is one of the low-hanging fruits here. There's also a not well understood increase of risk of myocardial dysfunction, however you want to call it, HFrEF, in patients who have chronic inflammatory diseases. Chronic cytokine states, chronic inflammatory states, acute inflammatory states are very adaptive if you want to escape, a cheetah that's chasing you in the wild, or fight or flight or whatever, right? But chronic inflammation is maladaptive. and chronic cytokine environments are maladaptive to the heart. We all know of patients who are in the ICU, critically ill with COVID or whatever, and you get an echo on them because they look like they have some kind of shock, and their EF is 20 or 25%, and then they recover and they get better, and 6 months later the EF is dramatically better, right? We all know that what chronic inflammatory states do, or even acute inflammatory states do to the heart. And so I think a heart failure collaboration in collaboration where I have a lot of patients with RA and lupus and other things and myositis and stuff and scleroderma who develop progressive heart failure with or without atherosclerotic disease, I think is another strong area of collaboration as well. So we're not up in the rheumatology world as much as we should be on heart failure management of the A, B, C, D, E, F, G, which flows in or non-flows in. I'm supposed to put someone on now, which, SGLT2 inhibitors. And I mean, it's a soup that's impossible for us in rheumatology to follow, but is necessary for our patients. Pulmonary hypertension is again, the more low-hanging fruit. Getting patients appropriately cathed when they need to be diagnosed, having them trialed on various medications, and having a clinic that can specialize in using, whether it's prostacyclin analogs, phosphodiesterase inhibitors, or endothelin receptor antagonists. These are complicated medicines, and the ability to judge their response in patients, which I'll emphasize again, is an art. The ability to look at both physiologic responses and clinical responses. And so I think these are the bread, the holy grail, I think, for these types of clinics. And then yes, there's always going to be the sarcoid patient that needs to be evaluated. There's going to be the patient with lupus and some unusual valvular heart disease or pericardial disease or cholesterol pericarditis and RA or whatever that will naturally fit into that clinic. But I think there are much larger populations of patients with atherosclerotic cardiovascular disease, myocardial dysfunction, whether it be diastolic or systolic dysfunction, and pulmonary vascular disease. I think that's a great place to start with a cardio-rheumatology clinic.
That's wonderful, Dr. Graffin. I completely agree with you. And when, first thing is that there's nothing, there's no flosin that you can go wrong with. And my fellows remind me of this very regularly. Hef, pef, hef, ref, we're good.
Right.
But yeah, that's been nice. But I will say that, when heart failure starts to get worse, it's one thing to have compensated heart failure in patients who are doing really well. But when it starts to get worse, especially when EF starts to decline, in a patient with underlying rheumatologic disease, we get very, very worried at that point because something's going on. And, I've had scleroderma patients where their EF starts plummeting because they have fibrosis in the ventricle. And we've really worked hard with the pulmonologist and the rheumatologist to, try novel therapies. And so far, so good. But I just don't know, over the long term, because we don't have good data. So it is something that we kind of, I think that's a great point about collaboration with heart failure. And so then kind of building off that to Dr. Mankad, what are some of the biggest challenges either you've encountered or you kind of envision, with cardio-rheumatology and with building a program? And you have touched on this a little bit, but even more in depth.
Yeah, so I think one of the things is just having people recognize that this risk exists. So despite the fact that, there are places that are doing cardio-rheumatology, they're big places, they're academic centers. I continue to be surprised when I give lectures that people are like, oh, I didn't realize that, or I didn't know the risk was so high. I've had, people come up to me from the audience who go, I have RA. Should I worry? I've had people come up to me and say, I've been on hydroxychloroquine for 20 years. Should I worry? So I think the challenge is that people need to take this seriously. I continue to see, even here at my own institution, the Mayo Clinic, where I'll see somebody who's had an MI and the notes will sort of list methotrexate as a med, but then nobody puts that their cardiovascular risk factor to having this event, they don't add the RA as one of the risk factors. So it continues to surprise me, but it tells me we still need to do more and continue to have these discussions. And we need to be aggressive. I also think that, yes, you touched on the prevention guidelines include autoimmune rheumatologic conditions. Yes, people say it's like diabetes. but it isn't on the guidelines. So all it is a enhancer. So when I tell a patient that, I'm like, okay, how much has it enhanced your risk? I don't know. And you know, the EULAR 1.5 actually hasn't been validated. We've done some of our own research. So do you just say 1.5? So I tell patients, I know your risk is higher, but I don't know how much higher. So we have an entire area that we haven't really looked at, because should we treat this person like a diabetic patient? Should we do something different? Should we be looking for subclinical disease more? The good news is, because there's no guidelines, I can kind of do what I want, which is kind of nice. So meaning I am very aggressive. I do look for subclinical disease. I do talk about statins earlier than probably a lot of my colleagues do, but it's not, so that's, it's a challenge because I'm doing it, but if everybody else isn't, that's not good, right? So then you're not getting equal sort of approaches to this. So I really wish there was something more in the guidelines that would help everybody approach these patients in a uniform way, because then if we do that, we're going to have a better idea of outcomes and what works and doesn't work, and are we doing better, and those kinds of things. So I think that's continues to be a challenge, despite this field being around for a few years. I think there's still a lot of unknowns, and until we collect things, and maybe exactly like this, having collaborative data, because obviously these conditions aren't common. So if you think about lupus, all of us don't have, you know, we're not talking about thousands of lupus patients that each of us have. So combining data is going to give us so much more information. So I think being able to work across the country with people who do this, because if you see, there's all these papers and they all kind of say the same thing, and everybody does their same thing with this sort of stable number of patients that they look at. And boy, if we could pool all of that, I think we totally benefit the patient in the long run.
I completely agree with you, Dr. Mankad, because I think that, you know, even if you're not doing cardio-rheumatology as a specialty, because there's so few people are, but people have a lot of experience. I mean, when I came to Stanford, everybody was doing this. It just wasn't under one clinic. That's the only difference. So I do think pooling resources and, you know, data is going to make a huge difference. And, you know, to talk a little bit about what you said about rheumatoid arthritis, we just presented a patient who's 47 years old. I think I told you about this case. She basically had like some chest pain and then has this multi-vessel coronary disease. But not only that, she has what looks like diabetic vessels, but she doesn't have diabetes. And then we look back, she's had RA for 20 years at 47, so that's been a while. So, you know, there we go. She's going to have a bypass most likely, but that's kind of, and it makes perfect sense, but it's not something that would get picked up that commonly. So that is really the key. So moving on now to Dr. Graf, and this is actually for both of you, but I'll start with Dr. Graf. So a little bit of fun stuff now. You both have diverse patient populations and you've seen many, many things. Could you briefly share an interesting or challenging case that you've taken care of?
Oh, you put me on the spot first.
Just one.
I'll tell you an interesting case. Okay. When I was, this is a commentary, I think, on new physicianing versus old fashioned physicians. And I'm sort of, as time goes on, I'm increasingly finding myself in the latter category, I guess, unfortunately. But I will have had numerous cases, but I think a very instructive one was we were called to see a patient who presented with joint pain to the hospital and shortness of breath, and on workup at a chest x-ray that showed an enlarged cardiac silhouette, which prompted an echo that showed a large pericardial effusion with potentially impending tamponade. This was a young woman, and this was admitted by the night team, who signed it out to the day team. They managed to get initial workup done, and you know, by chance, they ordered an ANA, and it happened to be the day of the week when ANAs are actually done in the hospital here. So they actually got the result back later that evening, and it was floridly positive. And so the consult was carried over to this was a team meeting at night, was to call rheumatology to see this lupus patient, and treat this lupus patient with new pericarditis. And so by the time we got around to seeing the patient after clinic in the morning, we saw the patient in the early afternoon, the team had gone home. And they had started the patient on I don't know, some significantly high dose of steroids to treat the pericarditis and a few other things, whatever, and went home. And I remember when walking to the patient's room with my fellow from across the room, you could see this was not a lupus patient. This was a patient whose face had the classic findings of scleroderma, actually. And of course, the largest pericardial effusions you'll ever see in your life actually are in scleroderma patients. There have been several New England Journal images in clinical medicine over the decades that love to show, pericardial tamponade in somebody with scleroderma. And so, and this was something you couldn't miss. Well, obviously, you don't want somebody with form-fruste scleroderma to be on 30, 50, 60 milligrams of prednisone. That's not good form. And we couldn't find the medical team to tell them that the patient doesn't have lupus. They almost certainly will have scleroderma, which is also ANA positive in 90%, 95% of the cases, and to get the corticosteroids off and to sort of go at this from a different direction. So it took us some time and a lot of cross covers and a lot of other things. And I don't think the medical team, because of all the switching and handing off that goes on these days, ever fully got a chance to see form-fruste scleroderma present right in front of them. They missed that opportunity. But it's an example, I think, again, of why it really does help to have collaborations between all medical specialties, because we all can add a little bit of acumen to every case.
Yeah, that's so true. I mean, first of all, scleroderma doesn't affect the heart. I mean, other than pulmonary hypertension, it doesn't affect the heart that commonly, but when it does, it tends to be really, really bad. And that's, I think, the one that makes us all pay attention when it has myocardial or pericardial disease. But I totally agree with you. I think, sometimes these patients, first of all, I still don't understand why we don't have stat ANAs. I think it would make our life much, much easier sometimes, but it takes a week and now they're back home. So that maybe that's another project. But moving on to Dr. Mankad, how about a case from you?
Okay, so I'll do this relatively quickly. I had a 26-year-old female who came to me for severe mitral regurgitation, known lupus. So came to me because I happen to work in the valve clinic and cardio-rheumatology clinic, so she got referred. So severe mitral regurgitation, and if you looked at this valve, it was very odd looking. Posterior leaflet was tethered. There was this really big posteriorly directed jet of mitral regurgitation, and she was mildly symptomatic. And as I was talking to her, her speech just sounded different. It wasn't necessarily dysarthric, but it just wasn't what I would consider a normal speech. And I asked her mother, has she always talked like this? Is this an unusual speech? And the mom's like, oh, she fell on her head and the speech changed. And I was like, what? Sounded very odd. And so I'm looking at this valve. Clearly, she needs to have something done. It's not a repairable valve. So you're looking at valve replacement in a 26-year-old who wants to have a family and who has lupus. And so I'm looking at this speech thing and I thought, I wonder if she's ever had anything happen to her head. So scanned her head and there's multiple strokes. Never been clinically identified. And I'm like, okay, this is concerning. And so then talked to my rheumatology colleagues and I'm like, I think she has antiphospholipid antibody syndrome. And lo and behold, she did. And the suspicion is that the valve probably had NBTE at one point, wasn't clinically relevant, but that a damage to that valve with the NBTE probably fibrosed the valve and tethered the posterior leaflet. Now, why is this all important? Well, the issue now becomes the type of valve. She was 26, anticoagulation, pregnancy, but now she has known antiphospholipid antibody syndrome. So she needs anticoagulation. She's had strokes. She has to have warfarin. So the decision was made to put in a mechanical valve because she was going to need warfarin therapy regardless. And so it was a fascinating sort of approach to this patient where it was sort of accidental that we even found it, because there would have been no other reason to look for antiphospholipid antibodies because she had no other clinical evidence of a hypercoagulable state. So it's kind of a cool case.
That is really a cool case, and it actually reminds me of a case I had as well. APLS, again, when it happens and it affects the heart, it's no joke. And you'll read the New England Journal articles about like catastrophic, like in all circuits of the body, there's been like disseminated thrombosis. But I have a young guy, and it's always the young people, which is the worst of it, because it's like the 20-year-olds or 27-year-olds. So I had a young guy who presented with, he was, I think, going to enroll in the army actually. And just before that, he had an accident and then a stroke. And the stroke was pretty catastrophic. And with the stroke, they found that he had the kissing lesions on his mitral valve. So classic Liebman-Sachs, and then he was diagnosed with antiphospholipid. So he wasn't on anticoagulation at the time, and so he was treated for that with warfarin. And his valve is actually not bad. He has mild MR. But when he came to me, he had palpitations, so I did a Zio patch, and he had non-sustained ventricular tachycardia, which is unusual for a 27-year-old. So I did an MRI, which I do. I have a very low threshold in my patients to do an MRI. And he had scar in non-coronary distribution in multiple territories. And I really think that when he sent those thrombi to his brain, he probably sent some down the coronaries as well. And everything's fine. His EF is okay, but it's very humbling, these conditions. Okay, and we're doing fabulously on time, which is, both of you are wonderful. But I'm going to go to the last couple of questions, and we have addressed this, but this is actually to both of you. I think we'll start with Dr. Graf first. So what do you think the future of cardiorheumatology is going to look like as a field?
I think there's a lot of things. I think, by the way, you just reminded me of another case that I saw of somebody with catastrophic antiphospholipid antibody syndrome, which can be very, very difficult to diagnose, very challenging, and can progress so rapidly. By the time you even can suspect it or convince people that's what's going on, it's almost too late. If somebody who had accelerated pulmonary hypertension that accelerated over the course of 36 hours, and we were trying desperately to get this woman anticoagulated as her platelets were dropping, and we couldn't get hematology. We thought there was heparin-induced, thrombocytopenia, and we're trying to get hematology to give us alternative anticoagulants, and they wouldn't approve it at the time, and they ended up dying, and it ended up being catastrophic APS. But anyway, so what's the future, right? So the future, I think, is better ability to understand the molecular mechanisms as to how our diseases collectively drive atherosclerosis, drive myocardial dysfunction, increased cardiovascular risk, as well as the mechanisms behind specific disease manifestations like you're talking about, whether it be Liebman-Sachs. How does the inflammatory process on the endothelia drive the Liebman-Sachs? We know in Liebman-Sachs, obviously you do anticoagulate, but you use anti-inflammatory, autoimmune directed drugs as well, because you need to tampen down the inflammatory effects on the endothelia. And we know in antiphospholipid syndrome, for example, it's not a simple clotting disorder. We know that there's inflammation that drives a lot of this. And in catastrophic APS, we use immune suppressing drugs in addition to anticoagulants. And we know, for example, that these antibodies, or either as bystanders or as direct pathogenic antibodies, are driving endothelial dysfunction, platelet dysfunction, and a lot of the factors that lead to arteriopathies and thromboses and things like that, and the complement cascade and all this stuff, right? So understanding these mechanisms, I think, is very, very important to the future of cardiorheumatology. So hopefully there'll be, as you alluded to at the very beginning of your talk, there'll be improved biomarkers to identify who with a rheumatic disease is at increased risk for cardiovascular disease, right? And get them referred appropriately to a cardiorheumatology clinic, or have this assessed in a cardiorheumatology clinic. So whether that's, so for example, we know that if you just take RA, it's associated with increased cardiovascular disease risk, right? But you don't know anything about how cross-sectionally RA disease activity is associated with cardiovascular risk, or in an integrated fashion as an area under the curve, how cumulative disease activity correlates with cardiovascular disease burden. So that's a lot of research that needs to happen. Here in a sort of our collaborations here, we've taken an interest in doing endothelial biopsies on people. Granted, it's from the venous side, not the arterial side, but we've begun to look at cell activation markers in patients with chronic inflammatory and autoimmune diseases to see if there are abnormalities that can be picked up that can clue us into who's at increased cardiovascular risk, and then potentially maybe identify some potential mechanisms by which inflammation translates itself to cardiovascular disease. So maybe we'll be getting endothelial cell precursors on people in the future, looking at circulating endothelial cells just on a routine blood draw, or we'll do simple, venous catheter related endothelial biopsies to look at the endothelial itself in a more directed way, or we'll be doing cardiovascular imaging, whether it's looking at flow mediated dilatation or pulse wave velocities or other things, to microvascular, velocities to look at accelerated cardiovascular risk and be able to characterize people appropriately and get them onto more potent, hopefully cardioselective anti-inflammatory autoimmune agents that can lower their cardiovascular risk. So I think that's a big thing to come, I think, in the future. And then I think, of course, as our understanding of the mechanisms of these diseases and how they affect the heart and the cardiovascular system evolve, there'll be an increasing role for cardio-rheumatology clinics, I think, to both address these mechanisms, diagnose them, address them, and treat them appropriately.
So that sounds like job security for us.
Yes, I think so. It's only going to increase.
All right, well, that's good to know. But what I was going to say, you're right, because the other thing is, we intuitively, you feel like if a rheumatologic disease is worse and has more disease activity, it should affect the cardiovascular outcome. But we need research. We can't just say we feel this. And the other thing that's important to acknowledge, when you ask a patient their rheumatologic history, one is when were you diagnosed, but two is when did you have symptoms? Because if you ask them, it's been 10 years, 20 years where they had this, things that were blown off as a little joint pain, a little rash, but they may have had it, untreated for much longer. So that's another important facet.
We don't have a hemoglobin A1C, right? If you're a diabetologist, right, you can look at the hemoglobin A1C and you have an integrated idea of what their glucose control has been like for a few months, right? You have no idea what someone's RA or lupus or scleroderma disease activity has been over whatever period of time it has been. With smoking, there's pack years. You can kind of quantitate that if you have to, right? But we don't have that biomarker per se, other than a patient telling you, or you following a patient yourself for 10 or 20 years and having some general gestalt. That's what we need to come up with, is like a hemoglobin A1C. That's
the next project. All right. Well, Dr. Mankad, from your opinion, and this is the last question, what is the future of the field?
Yeah, it's a great question, and would take an entire sort of discussion in and of itself. But I think one of the things is it continues to happen, like we talked about, piecemeal. So the goal in the future is to train cardiologists / rheumatologists to kind of focus on this and then allow their training to facilitate all the different aspects. So I started as an interventional cardiologist, but then don't do that. But coronary disease has always been sort of up and sort of high on my list. So the prevention and CAD part of the autoimmune and heart disease is sort of, I do that. I mean, it's done. I'm not a heart failure doc. I'm not an electrophysiologist. I work in the valve clinic, but not other people who do CAD don't do that. So the thing is, because you have a condition that affects all parts of the heart, the question is how do you train somebody as a cardiologist who can understand all those different pieces of how this affects the heart? So the future would really be to train somebody who is a multimodality imager, who knows about heart failure and the arrhythmia risk and pH. I mean, we have a pH clinic. I don't take care of scleroderma because it almost always goes to pH, and so that they have all the pieces of knowing how these conditions affect all of the heart. So if as a patient, you come to one cardiologist and they can take care of all these different pieces of how this autoimmune disease affects the heart. So that would be, I don't know if that is the future, but that would be something that I would love to see in the future.
Yeah, that's wonderful. And that was traditionally the role of a general cardiologist. It's just that we're so subspecialized now. But maybe cardio-rheumatology will bring back the general cardiologist. That's the hope. And the imagers, I will say. All right, well, that was wonderful. Thank you both so much. We have a couple of questions, which I'm going to pose to all of us. So the first question is from William Ock, which is, what is the most common cardiac pathology that is missed in patients with inflammatory disorders? So I'm going to open up that to our panelists.
So I'll answer that very quickly. I think it continues to be atherosclerotic cardiovascular disease, and it doesn't have to be obstructive. So I think that's the other issue, is people need to recognize that non-obstructive CAD, so again, being in the Women's Heart Clinic, we know that non-obstructive CAD is more symptomatic in female patients. I think the same holds true for the autoimmune patient. There's a ton of endothelial dysfunction in this patient. So I think that if somebody does a stress test and it's normal in this population, they're like, I'm done. And that's not right. So I still think the bread and butter CAD is missed. And then kind of the second one, which is a close second, is the heart failure. We know that RA patients have a lot of HFpEF, but the problem is a lot of them are deconditioned. They can be overweight. They can't exercise because of their joints. So often deconditioning is attributed as the reason for their dyspnea on exertion or being overweight, or, oh, it's some lung disease from their methotrexate, whatever it is. And people are not realizing that actually, the more recent data, especially in centers that are fairly aggressive, it's actually heart failure that's the bigger problem and not coronary disease. So those are the two.
Wonderful.
Yeah, I'll second both of those. That's why I alluded to the fact that I think this is the bread and butter for building cardio-rheumatology clinics anywhere, is atherosclerotic disease, heart failure, PH. I think that's just, that alone was enough business, I think, to drive any cardio-rheumatology clinic. And I think, Joan Bathan, who's the chief of rheumatology at Columbia, has built an entire research career trying to and gets on a soapbox all the time and has volumes of data to support this, both especially HFpEF and HFrEF in the RA population as a major morbidity, especially as patients are living longer, aren't dying of other things earlier in their lives. This is now a increasingly recognized complication.
Absolutely. And I'm gonna add to that, which is actually something that Dr. Mankad said, which is, in younger patients who have non-obstructive disease, they can have vasospasm, they can have microvascular disease, and some of them have had what my patient describes as squeezy chest pain for years. And then you give them a little diltiazem and they feel great. So there are other things that, all chest pain is not coronary disease, but all chest pain is also not non-cardiac. So I think there's a spectrum there. Wonderful. Well, the questions are coming in. Do both of you mind staying for an extra few minutes?
Yeah.
Okay, wonderful. All right. So the next question is to Dr. Mankad from Lua Jaffrey. Can you talk about your approach to ASCVD risk assessment and management of these patients, the role of CAC score, target LDL, and anti-inflammatories like colchicine? And actually, William asked the same thing about calcium scoring.
Yeah, so as I alluded to, because the ASCVD risk score just calls these a risk enhancer, I tend to be very aggressive and look for subclinical disease. We actually had a study that we did where we were actually doing arterial health studies, which included carotids to look for plaque. And then we were looking at pulse wave velocity to look at aortic stiffness, as well as endothelial function assessment. That was part of a research study. So we don't do that now routinely, but I do coronary calcium studies often in my younger patients. Now, in my Medicare age patient where they're likely to already have some plaque, I don't, and Medicare won't pay. But in my younger patients, I will do this. I do the risk score, and then I go, it's higher than this. And then I go, does that mean it's enough for statin? I never know the answer. And so depending on what else I can tease out, whether there's more than one risk enhancer, then I might just go down the route of lipids, of statin therapy. Or again, I do a lot of coronary calcium to look for subclinical disease. So I do that fairly frequently. And as far as the goal LDL, this is now a moving target, as we know. Now we've come back to a number goal for people with CAD or high risk of less than 70, less than 55, somewhere around there. In this population, I don't know the answer yet. I think lower is better for everyone. I had a former colleague here say, do you know what an infant's LDL cholesterol is? And people shook their head and he's like, it's 30. And do you see them having problems? So, I think lower is better. And in this population where this risk exists, I think driving down to something, certainly less than 100, maybe less than 70 is sort of the way to go. Whether there's a role for PCSK9 inhibitors to do that, jury out. I'm not going to say a word. Who knows? I'm sure they want us to test that, but who knows?
I completely agree with you. So if there's even a hint of a cardiac risk, but the patient is on the fence, or I'm on the fence about starting statins, I get a CAC scan because it's within the guidelines. It will help identify risk. But if their LDL is really high, then the CAC scan doesn't really matter. So I think it depends on each patient, but I certainly think it's important that we convey to them that they're not at the same risk as the general population. They are at a higher risk. So that's wonderful. Next, we have a comment by Dr. Goldschlager, which is always so lovely. And yes, Dr. Goldschlager, thank you so much. We do need more of our primary general cardiologists, and we'll bring back that specialty. I think that would be a goal.
If you can coax her out of retirement, that would also help as well.
Yes, you can mentor all of us. All right. And then our last question is from one of our stellar residents who is now a cardiology fellow, Dr. Ekpo. And Dr. Ekpo asks, and I think we can, Dr. Graf maybe can take this one, is Is there a role for integrative medicine in controlling inflammation who have concerns about escalating immunomodulators?
Absolutely. That's a fantastic question. So let me pose the scenario this way. It seems like anybody with any kind of inflammation these days. I mean, Ritker started an avalanche of investigating. He deserves a lot. He and Peter Libby, I guess, deserve a lot of credit for basically creating a world in which any kind of inflammation is bad, right? So if you have periodontitis and don't brush your teeth enough, someone has shown there's an increased cardiac risk there, right? If you've got, a chronic, hangnail, that's probably some cardiac risk there as well, right? Well, you can imagine. And of course, be the first to patent this as well. We'll get the CR. Maybe we'll be able to pick up. We have the high sensitivity troponin now that can go down to like 1/1000th of a millimole. Maybe now we'll do the CRPs down to that level as well, and have some risk continuum for cardiovascular risk. But and I say this partly in jest, but also to make a point to Dr. Ekbo. If these little things can be shown in a large enough population to correlate with an increase in cardiovascular risk, imagine what 1 or 2 swollen joints amounts to an RA, right? That's a logarithmically higher amount of inflammation in somebody's bad teeth. Okay, and a lot of times in a rheumatoid arthritis patient, if I'm a rheumatologist and I see someone and I'm treating somebody by Gestalt, and I saw someone who had 20 swollen joints and lots of inflammation, a year ago, and I put them on various medications, methotrexate and prednisone and hydroxychloroquine and things like that. And they come back to my clinic now with 2 or 3 swollen joints. Well, that's an ACR 70 response, right? That's like the highest level benchmark of response that we look at in clinical trials. You pat yourself on the back and you say, job well done. I'll see you in 3 months, right? But the reality is, what residual cardiovascular load do they carry, risk load do they carry by virtue of having a few swollen joints? Well, compared to somebody with a little bit of psoriasis or a few bad teeth, it's still probably quite a bit. And so what we don't know is whether or not accelerating immunomodulators, are our risk targets good enough? Are our disease activity targets good enough and low enough? Should we base it just on their overall clinical exam, or should we be looking at other internal factors like cardiovascular risk? And so, I'll give you another example. I think, in lupus, for example, a lot of times we'll put someone into remission, their renal disease or something else, right? But their serologic markers of inflammation remain high. They still complain of intermittent serositis and hair loss. There's and a few skin rashes, and there's obvious disease activity going on. Well, what is the cardiovascular burden in that patient? If you were treating somebody with cancer or lymphoma, would you be happy if I said your lymphoma is 70% better? When I have the opportunity to put you in remission, right? If I just advance your therapy a little bit more, there wouldn't be a single person out here who would say like, oh, I'll take the cheaper therapy that puts my cancer 70% better, as opposed to the one that puts me a little more expensive, that puts me into remission, right? So we have to be willing to go stronger sometimes on our therapies if that's what's required, if the data eventually backs up the fact that we're not treating to a low enough disease activity target to lower cardiovascular risk down to what it is in the general population. So that's the research that I think needs to get done. And I think right now, the lowest hanging fruit is to convince rheumatologists in general out there to not treat our diseases by Gestalt, but to have defined disease activity targets. And in RA, we have disease activity scores like the DAS that we can use to at least get patients down to low disease activity or remission. And in lupus, we have lupus scores, and spondy diseases, we have spondyloarthritis activity scores. And where a lot of our treatment is still by Gestalt, and we're still very happy with significant improvement, but we're not necessarily driving ourselves to low disease activity or remission. And I think that's where the research has to be done in the next few years to show that going to those targets makes a difference in terms of lowering cardiovascular morbidity and mortality. And if that's the case, we need to be comfortable pushing our immunomodulators to that lower disease target.
Absolutely. Thank you, Dr. Graff. That's so true. I mean, where we say we want the LDL under 70, we want the A1C under something, if in a cardio-rheumatology patient, we're doing that, but the disease activity is not at some target, which we don't know yet exactly what that perfect number is, then it's only half the picture. So I think that's a beautiful response. I think with that, we're done. If we have any closing comments from our speakers.
I think that covered it. I learned a lot. Thank you, Dr. Graff.
Thank you. I learned a lot as well from you. I will say in rheumatology, we can learn a lot from our cardiovascular colleagues. I will say, I mentioned Ritker a few minutes ago. The latest study that Paul published was a study called the CANTOS trial, where he somehow, in a way that I'm lucky if I can get 20 patients to enroll in a complex biological trial. He got thousands of people in Australia to take canakinumab, a biological an antibody against interleukin-1, to show whether it lowered cardiovascular risk. Well, he did show it lowered cardiovascular risk. He also showed that if you just give it willy-nilly to the general population, you also increase the risk of infections and mortality in other ways too. So it's not coming to prime time, but he plays tennis with a fellow colleague at Harvard, Dan Solomon, who's a rheumatologist. And Dan very cleverly piggybacked onto the CANTOS trial and said, well, geez, if you're giving thousands of people interleukin-1 inhibitors, we know that gout is an inflammatory disease. It's associated with cardiovascular risk. It's got a lot of inflammation in it. Why don't we look at the population of people who got drug versus didn't get drug and see if gout flares in people who had known gout and people who didn't even have gout were lower. And sure enough, they published a paper in the Annals a year or two later showing that canakinumab is an effective treatment and prophylactic for gout. So we can learn a lot in rheumatology from our cardiovascular colleagues in their clinical trials as well.
Well, thank you so much. It is a beautiful collaboration. I think we all learn from each other, and it really is systemic cardiology, which I like to say to everybody. But with that, I think I'm going to close the meeting. Thank you all so much, Dr. Mankad, Dr. Graf, and our other panelists for your participation. And I think this will be recorded for anyone who missed it. And thank you.
Thank you.
Thank you.
Thanks.